Good morning, good afternoon, good evening to our audience around the world. My name is Ayman Sabae, and I'm the Managing Director and the Legal and Judicial Director at the Tahrir Institute for Middle East Policy. It is a pleasure to welcome you all to today's discussion, COVID vaccine access in MENA. Our event today, which focuses particularly on North Africa and the Levant, seeks to begin a much needed conversation to unpack what vaccine access and distribution has looked like across the region, how pre-existing health and information systems have affected this access, and what access has looked like for the region's vulnerable populations, from refugees to prison populations, and those in conflict settings as well. Our panel brings together a dynamic group from different disciplines with different country areas of expertise. We invite you as audience members to submit questions via the question and answer function on Zoom throughout the event, but note that we will dedicate the last portion of the event particularly to answering those questions. I'm now pleased to introduce your moderator for today's discussion, my colleague, Ghinwa Hayek. Ghinwa is a non-resident fellow at TIMEP, focusing on COVID, public health, and access to data and information in the MENA region. She works mainly in the fields of maternal and newborn health, mental health, and now on COVID in the academic and humanitarian sector in Lebanon and the Middle East. Ghinwa, the floor is yours.
Yes, thank you, May. Hi, everyone. Happy to be here and happy to have you here. I hope you'll enjoy this session. I'd like first to introduce our amazing speakers and panel of speakers. So first to start off with Ayman Sabae, and he's the co-founder and CEO of Shamsiya for Innovative Community Healthcare Solutions and Right to Health researcher at the Egyptian Initiative for Personal Rights. We also have Shea. She's a non-resident scholar at the Middle East Institute focusing on information control, security, political repression, authoritarianism, and the impact of technology across the Middle East and North Africa. She also consults for the World Bank. Dr. Aula Abbara, she's a consultant in infectious diseases and general internal medicine at Imperial College, NHS Healthcare Trust, London, and an honorary clinical senior lecturer at Imperial College. And finally, Dr. Jasmin Diab, who's an assistant professor of migration studies at the Lebanese American University Department of Social Sciences. She also serves as the Refugee Health Program Coordinator at the American University of Beirut Global Health Institute and as a research associate under Global Health Institute Political Economy of Health and Conflict Workstream. Just not to be any more late, let us start with a round of discussion and the questions for our speakers today. First of all, let us discuss a bit the vaccine rollout deployment in the MENA region and what it has shown us in terms of barriers, accessibility, what are the lessons learned, and how we can move forward. Ayman, how do you think like the health systems and policies or strategies in place originally and then for COVID affect the distribution or accessibility to vaccines?
Thank you very much, Ghinwa, and thank you for this kind invitation. So first of all, when we're discussing inequity, I think it's important to be clear on what it actually means. And the WHO has a rather complicated definition of inequity. It defines it as the absence of avoidable or remedial differences among groups. But actually, I think the main point that we need to focus on when it comes to equity is that the difference between equity and equality is that equity recognizes that each person has different circumstances. And through equity, we need to allocate different resources in order to give people access to the same opportunities. Because in the end, we want to have an equal outcome. And this is really the core of equity. Now, when it comes to vaccines, especially in the context of COVID-19, the major challenge that we're facing is that we have this very nationalist-based system around the world. Democracies, decision-making, policies, they are all based on a group of people defined by a geographical barrier, and they have some sort of control more or less, of course, over who takes decisions on their behalf, and those decision makers are to some extent accountable to their populations. When it comes to a global pandemic, this equation is not suitable to address global inequalities or global inequities in that case. This is why in January 2021, the WHO issued a call for all countries to work together in solidarity. And it set a goal that within the first 100 years of the year, vaccination of health workers and older people should be underway in all countries. So, setting a basis for what would vaccine equity in that context mean. After those first 100 days, indeed, countries and individuals and organizations signed the Vaccine Equity Declaration, and over 500 million vaccine doses have been administered worldwide, with over around 38 million of them through the COVAX facility, in order to supply these vaccines to countries which are at the lower end of the economic spectrum. However, the lack of supply and inequitable distribution of vaccines around the world still remains a major challenge. And when we're talking about a global pandemic, the nationalist-based ideology that governs the vaccination production and distribution process is highly fatal, not only to the countries most affected by these inequities, but to the entire world. And the very clear and vivid proof of that is the situation in India. How we can all see how the situation in India affected the whole world, not just India. When we're talking about vaccine equity, this is a major consideration, not only from a human or an ethical or a moral perspective, but also from an epidemiological perspective, a financial perspective, and economic perspective. Because in the end, countries that are currently, for example, suffering from different variants of COVID-19, they originally originate from countries that did not have sufficient access to vaccines, which allowed for these variants, which allowed for these mutations to happen in the first place, and so forth. And so this is really important to consider. We're not doing this just because it's right. We're doing this because it's smart and because it is the only way out, not only for our countries, but for the entire world. And this needs to be the predominant language to be using. This should not be a call for action from people who believe in human rights, who believe in equal access to all, who believe in health for all. This should be a call for action for even those who operate with a purely financial and economically driven perspective. When it comes to healthcare systems and the kind of discrepancy that we can see in vaccine distribution, I actually found something that may be quite interesting to show this perspective. You should be able to see it on the screen now. This is a compilation of people who were vaccinated against COVID by yesterday, actually. And as you can see, I put here most of the countries from the MENA region, but I also put some references from other countries from around the world. And as you can see, now this is the dark green. This is the share of people fully vaccinated. These are people who are partially or partly vaccinated, and this is like the total vaccinations we can see. Now, as you can see here, actually, the UAE, Qatar, Bahrain, Saudi Arabia, it comes within the higher spectrum of people, of countries with the highest rates of vaccinations around the world. The UAE actually comes higher than Canada and the United Kingdom. So when we're talking about inequity, we're not just talking about inequity within regions, we're talking about inequities within the same region. And this is why we cannot look at the MENA region as one coherent case anymore. The difference is striking. We're talking about 77% for the UAE, for example, compared to less than 4% for Egypt in terms of vaccination rates. And if we look at the distribution of vaccines around the world, this is from the New York Times, and it's a very interesting map because it actually allows you the different levels of zooming you can actually look at, and you will be able to see the major differences. And the two most striking things to look at here is Saudi Arabia, with its 23 million doses of vaccine, which is 68 per 100 people, compared to Egypt, which is 5 per 100 people. But we should also look at Morocco. Morocco has a total of 21,000 doses administered, which is 58 per 100 people. And, you know, maybe we can say that Saudi Arabia has a different, you know, financial, economic situation, but here this is a case to study because it's not only about the finances. We also, I also want to show you something when it comes to healthcare workers, the number of physicians per 1,000 people. If you look, of course, this map has lots of missing figures, as you can see. The white are missing figures, but there is a considerable discrepancy when it comes to the number of physicians per 1,000 people, and it kind of mimics the patterns that we can see in COVID vaccinations and in the kind of services that are available. However, if we compare Tunisia, for example, with its number of doses and its 21 people administered vaccines per 100 compared to Egypt, this does not reflect the current crisis Tunisia is facing. So it's not only about the number or percentages of vaccines. It has to do primarily with how the healthcare system functions, with how it is operating, the kind of capacity of the government to communicate messages, the governance structure, and in some cases, the capacity of the government to act. And this is a major difference that we need to look upon as we continue our discussion. I don't know if this answers your questions in any way.
No, thank you, Ayman. This was a very detailed answer, and I think you touched upon many important themes that we could also elaborate on. You touched upon a bit on like how the government could relay information, which probably Joey will be more talking about, but also the inequities that we have in the region between the different countries, which probably also Jasmin will touch about, focusing on refugees. But I think there's also a very important point that was mentioned, and it gave me an idea of how, for example, WHO put, you know, they had the goal for the first quarter of the year, and which is we're past that. We're at the second quarter. We're even at the end of the second quarter. We should have vaccinated all of the healthcare worker, but I don't think this is the case everywhere. And perhaps Dr. Aula would also give us more insight on that. And you know, with healthcare worker in conflict and crisis, because you know we're seeing this now in the region and with the low vaccination. Just to go into my second question and well, to try and continue the thoughts of or like the thread of ideas. So to continue with the idea of inequity. So Jasmin, as your work focuses more on refugees, marginalized population. How do you think the system was inequitable to them? How do you think there was issues of accessibilities for them? And what you can tell us about that?
Thank you so much. Can you hear me? Is my voice clear with the microphone? Excellent. Thank you so much for your question. The MENA is a complicated region to discuss when we talk about vaccine rollout and vaccine equality, because there are so many political economic factors that play into this. And we see this in each and every country in the region that currently hosts refugees and that's currently battling with its own inabilities in the areas of its infrastructure to even satisfy the needs of its own population. In the MENA at the moment, 15 countries have begun vaccinating refugees, according to the UNHCR. UNHCR coordinates this throughout the region with different stakeholders. And at the moment, 19 out of 19 countries in the MENA have placed refugees in their vaccine rollout plans. As we know how the region works, it's always important to frame these initiatives within the larger political and economic context that they're operating in. having refugees as part of your national vaccine rollout plan does not necessarily mean anything in the areas of access, in the areas of vaccine equality, and also, as I'm sure Joey will touch upon, in the areas of access to information about how to get vaccinated, when to get vaccinated, what your rights are, and where you have access to these rights. At the moment, countries throughout the MENA do have plans. I can touch upon a few of them. Algeria at the moment has a very decreasing trend in the areas of cases that are positive in their Sahrawi camp, their Sahrawi refugee camps. Egypt has also enhanced this registration process to enhance its capacity to have refugees included as well. Even countries such as Lebanon that currently battle with two very large factions of refugee populations have, according to the Minister of Health, of course, placed refugees at the same level of priority. Everyone in Lebanon will get the vaccine as well, but access, of course, is very different. If I can touch on Lebanon a bit, as of April, between April and May, Human Rights Watch reported that only 36,000 Palestinian refugees were vaccinated. And only 1,159 Syrian refugees were vaccinated, although the combined number of refugees that were eligible for the first phase of the vaccine was 26,000. So now as Lebanon moves through phases of the vaccine and as institutions and employers vaccinate the larger population, who is keeping up with how many refugees are eligible for these phases, who's providing this information for them, and who's following up on whether or not they get their first or second dose and whether or not they're actually integrated properly into this. We see a major lack in that. In May, the Minister of Health in Lebanon said that maybe a little over 2%, if I'm not mistaken, of those vaccinated were even non-Lebanese, and only 5% of the people registered for the vaccine were non-Lebanese. Lebanon, I think, is a very big example of how, even though the initiative was taken and the statements were made, how in application this is lacking. Countries across the region, in Syria and in Northwest Syria, have also been battling kind of through different UN agencies of how to implement this. Many of the countries in the region, Syria being a large example, does not have a clear line of authority or a nationwide plan, right? You have to navigate different actors, different political contexts, different international organizations, and who has access to who and where. So if I were to summarize my response, I think vaccine equality in the region is rooted in political and economic hindrances. At the moment, there is a major access to information lack among these populations. There is currently no really witnessed in the region national strategies, even among countries that are actually working on local production of the vaccines, as we'll discuss later on in this, of how to reach these hard to reach populations. And while the will is there, intersectional and layered conflicts, as I said, such as Lebanon as well, that's currently battling with post-blast era political stagnation, economic stagnation. There are so many layers that you need to navigate before you get to the COVID vaccine. And then so many populations of concern that you have to navigate as well. So I'm not sure if I can frame an entire region in one response, but I hope I did a little bit. Thank you.
Yeah. Thank you, Jasmine. No, I think that was a very interesting response and summary that you gave, and perhaps we can discuss further of maybe lessons learned and how we can take this forward and move with this. But before doing that, I'd like to hear from Aula, and how would you think the region and the many conflicts, wars, and disasters we have, how did it impact vaccination intake, especially focusing on those regions that are a bit more destabilized? But also, I'd like if we can focus on a point also of in countries such as Yemen, Syria, country really in war and conflict. How has the intake of vaccination among healthcare workers? Because I know you are, as an infectious disease, I'm pretty much sure you responded to COVID directly and you were at the front line. So how do you think the intake of the vaccination among healthcare workers was, in the different countries in the region, perhaps? Yeah.
Cool. Thank you very much, Ghinwa. So essentially, conflict devastates health systems. It also politicizes them, it fragments them, and it politicizes humanitarian aid. And that just doesn't go for health and humanitarian aid, but also now for the conversations that we're having around the COVID-19 vaccination, which across the world is a very hot political topic, going even beyond the normal politicization of health that we have seen across the Middle East region, but particularly in those areas affected by conflict. So you mentioned Syria, Yemen, Libya, potentially even Iraq and Sudan, who are suffering tremendously due to often protracted, violent and complex conflicts. In terms of the devastation to the health system, this has a very direct effect on vaccine entry into these countries, the negotiations around vaccine access, access for populations who are in themselves marginalized. So we've spoken about refugees, we've mentioned those who are imprisoned populations, those who are held in detention, but also those who fall foul of the government. And remember, in Syria, given the criminalization of the provision of healthcare to those considered opposed to the government, they themselves are considered to be against the government, and they may not have the same equity to healthcare, let alone to COVID-19 vaccination. And that even goes for healthcare workers who, as we have discussed, should be very much a priority as they are on the forefront of the COVID-19 response. I'm going to touch on Syria as a starting point, just to give an example of what conflict does to health systems, and then what it does to COVID-19 vaccine access. So as Jasmin has said, when we think about Syria, we can no longer think about it as an entire entity under one jurisdiction. There are areas under government control, there are areas in the northeast under autonomous administration control, areas in the northwest under opposition control, and there are areas under Turkish control. And within each of these, there are different health systems or subnational health systems which function entirely independent in very different ways. And increasingly, there's very little communication. So a few years ago, there used to be more cross-line transfer of health or humanitarian aid. This very much isn't the case now, which is why we are so reliant on cross-border aid. There's another group that are particularly vulnerable, and those are those who've been internally displaced within the country. And that not only goes for Syria, but also Yemen and other countries, because they may be now in areas under government control, but actually they may not get the same equity in terms of health or humanitarian access, or even COVID-19 vaccination access, because they may still be in some ways politically penalized for having stood against the government in their country. And we know at the moment, for example, Daraa, which is in the south of Syria, is essentially under siege, and the people there are suffering tremendously, even though they're in an area now retaken by the government. What it means in terms of the effect of conflicts and the negotiations around vaccine is that they're being negotiated separately. So if we think about Syria, and the reason why we as Syrians are so reliant on cross-border aid. So many of you will know that very recently the UN Security Council resolution on cross-border aid was partially renewed with heavy political influence from Russia and other actors. Is without this, and we see this from the example in northeast Syria, there's a reliance of aid coming through Damascus. And even with the WHO and other international actors, I don't think we can say that there is equity in the distribution of health and humanitarian aid to areas across the region which are under government control or in the northeast of Syria. We've seen that to a devastating degree in terms of COVID-19 support, in terms of testing capacity, access to PPE, access to IPC interventions, access to training, which is provided through the WHO. So all of us would be very concerned should all vaccines come through Damascus, because we don't think it's going to be equitably served across the country, obviously prioritizing healthcare workers and those with chronic diseases. What this means in Syria is that there's a number of different supplies of vaccine. So we have a Chinese vaccine, we have vaccine from COVAX produced by the India Serum Institute, and the supply to government areas and the northeast is different from the supply that came to northwest Syria. One thing I want to touch on very much is the effect that protracted conflict, the criminalization of health and humanitarian aid, and the decimation of the healthcare workforce has had on healthcare workers. So thousands have been forced to flee, more than 900 have died, often as a direct result, have been killed, not died, so killed as a direct result of the conflict. And so for these healthcare workers, they themselves are working in this strained healthcare system, and they need to be protected. But of course, and I've spoken to healthcare workers in Yemen and in Syria and elsewhere, and very interestingly, some of them themselves hold ideas about the vaccine. So they themselves might have vaccine hesitancy. And of course, as healthcare workers in the Middle East region, we know that doctors are usually quite respected within the community. So they could potentially influence the uptake among other communities in the wider community, and that could affect vaccine uptake. There may be hesitancy. And of course, you may have followed some of the discussions around the very rare side effects, but sometimes fatal side effects relating to some of the vaccines produced by AstraZeneca that come through the COVAX initiative. So some people might say we're getting a second-rate vaccine. We're not getting, a vaccine with a better side effect profile, or the vaccine is being produced outside of Europe, for example. It's being produced in countries where we may not trust the vaccine to the same extent. And then lastly, the estimates within Syria, for example, and I'm sure Yemen is probably quite close behind, is 50 to 70% of health facilities have been destroyed. So they are barely functioning. So of course, for vaccine distribution, less so with the AstraZeneca vaccine, more so with the Pfizer vaccine, which we're not seeing quite as much of in the Middle East. You need a solid infrastructure with a cold chain to be able to distribute across the country. And of course, in areas affected by conflict, particularly where the conflict is heavily politicized, increasingly protracted and complicated, we won't find that to be the case. There won't be equity in the distribution across the country. And what that will do is widen disparities that exist across our region, causing more friction, more tensions within our communities. And that could well have long-lasting effects at a time where COVID-19, we certainly haven't seen the back of COVID-19. So I'm going to stop there.
No, thank you, Aula, for this, very detailed answer, I'll have to say. And focusing especially on, Syria as a case study, but also touching on other different regions and highlighting how much conflicts, war destabilizes the health system and how powerful it is for us, and how it just really doesn't help in times of pandemics and crises, and how it actually exacerbates inequities in access to not only vaccines, but as we were mentioning, even like equipment like for protection equipments like PPEs, or even healthcare, just healthcare, normal healthcare. My final question to you, Joy, now. Many of our speakers here have touched upon the fact of how much information and access to information is important for the management of the pandemic, let alone the management or the administration for a vaccination campaign. So how do you think this management of misinformation, disinformation in the region affected specifically the intake of the vaccine? And how do you think the information, let's say, surveillance system we have in place also, or the rules and the policies we have, did also affect the intake?
Yeah, it greatly impacted the vaccine rollout, just to say that off the bat. Obviously it's not the only factor that's important, as everyone else has mentioned. The capacity of the healthcare system and governments are incredibly important, but also a very proactive, so meaning defensive and offensive approach to containing and controlling the information ecosystem is hugely important. So, and it also depends on what state that we're talking about. So I'm going to just do a bit of a comparison between the Gulf and Egypt, because the difference between these, the internal regions couldn't be more stark, as Ayman mentioned earlier. And we see really big differences in the sort of tactics and broader strategies of these states. So if we just take the information ecosystem, Saudi Arabia had a very, very proactive approach. All levels of government, and throughout the course of my research, we noticed we're tweeting in tandem. They were tweeting in coordination, they were tweeting frequently. The information that they were getting out was consistent. There was information about the safety and effectiveness of the vaccines. And there was also very clear information about who is eligible, when, where to register, how to register, where to go, very detailed logistical information about, where to actually get the vaccine. And this wasn't, just a single effort. It was continuous. It was through all levels of government. And they also engaged large influencers to, people who are not just the state or the Ministry of Health. They engaged popular influencers to help get out this information as well. And once people started to actually take the vaccine, they used these popular figures to show that the vaccine was indeed safe and effective. So for example, we have this very viral tweet of MBS taking the vaccine, King Salman as well, and not even just political figures, but sort of popular figures as well, celebrities, musicians. And, of course, Saudi has access to different sorts of resources, but this was a very effective messaging strategy, and especially the engagement of influencers and popular figures even before the internet. This was always been identified as a really important, public health outreach strategy. There's also a lot of nationalism in this content. So, Saudi had its rollout very early on, and so there was this one very viral tweet, just as an example, of an American, speaking in English, but it was translated into Arabic, saying that, he had received his dose before any of his American friends, and this wasn't the only sort of nationalist tweet or messaging, and these sorts of steps were seen throughout the GCC countries. It's one of the benefits of having an incredibly centralized and controlled media and information ecosystem, and we can talk about the other sort of effects of that in a different panel, but at least for the purposes of the COVID-19 vaccine rollout, it was quite effective. And so I want to take Egypt as a sort of foil to Saudi Arabia. I think their website was launched at the end of February, beginning of March, their vaccine registration website. And, obviously this was a good first step, and it was limited to healthcare workers at the beginning. But it wasn't until, quite later that there was any information available to people about how they would get access to the vaccine if they didn't have internet access. And later the health minister said that people who were not able to register through the website could go to the hospital and register. But again, this information wasn't very clearly communicated. It was communicated late. And overall, their messaging has been very, very mixed. There are very little TV ads, very little billboards, very little non-internet avenues for spreading this information. And even just to take for an example, the issue of whether or not Egyptians were going to need to pay for the vaccine. This was very confusing for in the early months of the vaccine rollout. It wasn't clear if individuals were going to have to pay for the vaccine or not. And if you can't even get this basic information out there in a clear, concise, effective manner, then your ability to combat, harmful disinformation, it's going to be really problematic. And so, as I said, there was sort of this lack of a clear strategy. More broadly, and particularly with vulnerable communities, people in informal settlements, the rural poor, refugees, migrants. It takes a different set of resources to reach these communities. And if there's not even a broader national campaign to promote the vaccine, these communities are obviously going to be excluded. And so, I think that if we sort of take these two cases, these two states as case studies, it's really, the difference couldn't be more stark. And what's really necessary with these vaccine rollouts going forward is clear, consistent messaging, different strategies to reach hard to reach communities, different allocation of resources, depending on the vulnerable groups that you're trying to reach. So broadly, the information management system impacts this immensely, and we can go into a bit more details later, but sort of general overview.
No, thank you, Joey. And maybe I can add one point here. There was a funny example from Lebanon a couple of weeks ago where like the government added a layer to the vaccination. So we have like, you know, the usual COVAX, we call it, where we're registered to take the vaccination. So for like one weekend, they added an additional layer where you have to register on another website to get your appointment, while usually you were getting an SMS whenever your turn was coming back. So here's just like a perfect example of how they make it very hard for vulnerable people, for people who, you know, digital literacy is also a problem in the region, you know, owning phones, 3G, internet, and so on. So, you know, adding those layers of access. So this is,
yeah, totally.
that example came to mind when you were talking about it in Egypt. So
Definitely.
Yeah, and I think also the digital divide is important as well. And this was, you know, a big topic at the beginning of the pandemic is, you know, as everything is going digital, how is this going to exacerbate pre-existing inequalities? You know, and the fact that in Egypt for a long time, you could only register via this link, you know, and it's not even just the rural poor or, you know, informal people living in informal settlements. It could just be the elderly, you know, it could just be people without a smartphone. And that's a really big problem.
Exactly. Just perhaps just to conclude this round of questions and this first round with the theme of related to the deployment of the vaccine in the region. So maybe each one of you could say like a point of what could be the lessons learned to move forward to, you know, limit the barriers, increase accessibility, and how to make this an overall good experience, let's say for, I want to say beneficiaries, but basically for all the people living in the region. So let's start with Ayman. Just 1 minute and 1 point.
Perfect. So yeah, I mean, when it comes to information systems and communication, I think that if we continue with Egypt as an example, Egypt has shown in the past period how capable it is of actually going through massive campaigns related to public health. The case of the early detection and the treatment of hepatitis C patients in the last couple of years was an example of how capable the government is in communications when it wants to. And this is, I think, the critical point. It's not a matter of resources and capacity to communicate as much as it is about what are the resources that the country has when it comes to vaccines. I think that since the available vaccine doses in specific countries are already quite limited, it goes against the national strategy to go on massive information campaigns that would increase accessibility to vaccines, simply because the country is still trying to cover the gaps it has between supply and demand. On the other hand, as the country is moving towards national production and towards securing a larger number of doses, it is expected to begin engaging in these campaigns. However, and speaking on positive lessons or lessons learned from the last period, and I would draw again from Egypt in this case, there is a positive story to tell regarding responsiveness of the government to calls from civil society. Because the gaps that were present in information, especially regarding whether it's going to be sold, whether it's going to be available for free, outreach campaigns, civil society has been vocal about this, and the government has been relatively responsive to that. On very specific issues such as access to vaccines to people who are in custody, the idea that the proposition that was first actually given by the Minister of Health, that the vaccine is going to be sold for people who can afford it, this was completely put out of the equation following calls from civil society, but also the idea of going through outreach programs that target vulnerable populations, elderly people, to where they are. So this is, in that context, a positive lesson that if you increase the capacity of the government for good governance, for engagement with civil society, chances are you're going to get it a bit right, even with limited resources.
Yes, thank you, Ayman. I think this does apply to other countries in the region with limited resources as well, but also they can be innovative in how they like direct their resources and their capacities. Jasmin, one lesson or 1 point to how to move forward with this?
Definitely. Lebanon is an interesting case because refugees in Lebanon are either hesitant to receive the vaccine or don't know how. They're either misinformed or uninformed. There are no clear channels of information as to how vulnerable groups not only gain access to the vaccine, but gain access to the steps that it takes, as you were highlighting, to register, to be in line for whatever vaccine they're supposed to be getting, whatever phase of the rollout we're at. In order to combat this, a few things need to happen. Lebanon needs to ensure that priority groups, of course, as defined by the country's national vaccination plan, also trickles down to the refugee population. A lot of the refugees that were eligible for earlier phases of the rollout did not make it just because of this fact, because of the fact that the information and the follow-up was not there. How we combat this as well is we build vaccine confidence among refugee populations. So as I said, refugees are either uninformed or misinformed. There's a lot of hesitancy among many different groups within the refugee community to get vaccinated because of the things that they hear. From unreliable sources on social media, from the little information sources that they have. And in order to ensure that the right information is getting to the right people, Lebanon needs to address the bottlenecks faced by refugees for registering for the vaccine. And these bottlenecks, as you said, include these online platforms that are inaccessible and unrealistic, these many different stages, these many different websites, these many different inaccessible places that refugees cannot reach. As we said in Lebanon, a lot of political factors and a lot of human rights discrepancies play into this. A lot of refugees won't cross an official checkpoint because they're afraid that they will be stopped. Even though the Minister of Health in Lebanon has made a broad statement that regardless of your registration status or your residency permit or whatnot, that you should get the vaccine, a lot of the people in the refugee community are not given this information. They're afraid to leave the proximities that they're in for these reasons. And I think this is one of the major lessons learned at the moment. People are not leaving their areas. And then, of course, how we combat this as well as we implement special measures for underserved areas. We work with grassroots organizations, with local community organizations, CBOs, and we ensure that the people on the ground that really know the facts of what's going on, know exactly who's vaccinated, who's not, what they need, what their needs are involved in this rollout, especially in regions in the far north, such as Akkad in Lebanon, in the far south, and all of these groups that also present some of the most vulnerable within an already vulnerable population. And I think I'll finish by talking about the security concerns, really genuinely. Lebanon is not necessarily trusted in how it manages people's information. A lot of refugees are very afraid to register on any portal for whatever reason, if they have the information or they don't. They're afraid of being deported. They're afraid of their information being given to the wrong people. They're afraid of when they go back to Syria, they're going to get in trouble. I have heard answers that are completely diverse and have nothing to do with what the reality is because of the things they hear. So I think considering security concerns and access to information need to go hand in hand.
Yes, thank you, Jasmine. Aula, what would you like to add to that, to this point?
I'm going to perhaps be a little bit controversial and say, actually, I think refugees' security concerns are very valid, given some of the public health messaging and some of the messaging from various governments across the Middle East. So I'd be very sympathetic if people didn't want to go through checkpoints, because sadly, there's increasing discussion about forced returns to Syria. So I think we can treat that with sympathy. I'm going to keep this very brief, and perhaps it's well, I'm going to start with a facetious comment. I think to address situations in conflict, we need to stop conflict. We need to understand their root causes, and conflict must cease. Even this morning, several civilians were killed in northwest Syria. Many children, numerous children have been killed in the last few days, and that's devastating and unacceptable. In terms of, as we look at the region, we need to be respectful and mindful of the right to health for every individual in our region, regardless of their registration, their ethnicity, their religious persuasion, or anything else that we may label them with. In addition, and I don't want to make a broad statement, but some countries in our region have for a long time struggled with their public health infrastructure. And so across the region, COVID-19 has shown us that we must do everything we can to strengthen our public health infrastructure. And that includes outward messages. So we've heard some really good examples in some countries about public health messaging, which has been effective, albeit perhaps nationalistic. But I think that's something important for us, and whether that's in social media, but also down at the community level through community healthcare workers and others who could be trained to support people in terms of understanding their concerns and what barriers they may face. And lastly, for me as a healthcare worker, and someone who has spoken to a number of healthcare workers across the region, and following on from the graph that Ayman showed around the state of our workforce in the region, we really must invest in the healthcare workforce, because without doubt they could be among the best advocates around vaccination, but also other aspects of health and public health in the region.
No, exactly. Joey, any last point to add on the subject? That was very much, the last different points were very much related to information. So
yeah, I think there's been a lot that's been said about sort of state policies towards conspiracy theories, mis and disinformation, but I think it's also important to recognize the responsibility that American social media companies have to controlling this infodemic, as it's been referred to previously. Twitter, Facebook, they've all made big promises to clamp down on the amount of conspiracy theories, mis and disinformation that are just running crazy on their platforms. But again, I think we've seen the implementation has been quite limited. And we've seen implementation of these policies in the US and on, for Western languages like English being limited to what was promised. And so that doesn't even, pale in comparison to the lack of implementation for non-Western languages, specifically Arabic, and considering, different, dialects as well. And so, yeah, I think that this, the majority of disinformation and misinformation, conspiracy theories does come from social media. And it usually comes from a handful of influencers that are responsible for the vast majority of disinformation out there. There's usually like around a group of 10 individuals who are responsible for the vast majority of this content. So I think that really we need to start looking at the role of these Facebook and Instagram and Twitter in the Middle East, and their responsibility to really clamp down on this harmful mis and disinformation, because they're really not doing enough, and the inequalities are quite stark in the way that they moderate content in the Middle East and in the US. And they're not even doing that good of a job in the US. So that is quite frightening for folks in the region.
yes, well, thank you all for this great round. So I think we did kind of summarize now the issues we have in the region in terms of the policies that we need to ameliorate, in terms of, as you were saying, Joey, in terms of access to information, or true information, if I want to say, and limit misinformation, but also the barriers and the problems we have in accessibility, and how it is very much dissected into something physical. So just really going to the center, or having a proximity to the center, the security issues around it, and also the fact that access is also access to information, and how all of this does trickle at the end of the day in having perhaps like an equitable distribution of the vaccines, not only among one country, but among also the countries in the region. And how, well, unfortunately, the healthcare systems in our region are very much politicized, and also this is very much impacting the distribution. So we were perhaps a bit overboard in the time for this round, but then I think the next round will go much faster. And while this round was more on, let's say, public health, healthcare, the other round will touch more upon in public policy, and the subject for it will be actually about vaccine diplomacy, and how vaccines are political agents, and how they're being used as such in the region. So just a change of topic. So actually, I'm going to be starting again with Ayman. Ayman, like from a health system, let's say, more on the manufacturing side, so supply demand, how do you see the production of vaccines in some countries in the region? And I think you did like you as Egypt, for example, or you were mentioning Morocco being a very interesting example in the vaccination drive it has. And I've heard news that it might perhaps be being in talk of producing vaccines. So how would this production of vaccines in the region, and also it depends on which vaccine we're going to be getting and we're going to be producing, of course, would speed up the vaccine process.
Yeah, okay. So first of all, there was a statement that was actually shared by a colleague, Dr. Ahmed Shilbaya from the University of Columbia, and he noticed that the CDC director stated that it is the situation that we're having right now is a pandemic of the unvaccinated, which means that this is no longer a global pandemic with the context that started more than a year ago. Now we're talking about whether those who are not vaccinated are going to get vaccinated, and are they going to get vaccinated in time in order to prevent getting infected, and on the other hand, whether this is going to be efficient enough and rapid enough to avoid more mutations and more variants, which is delaying the global healing process against the pandemic. Now, when we're talking about local productions of vaccines, I think it's important to put it in the context of the intention. Why would a country consider local production, and what is it capable of doing? So to be very clear, all of the discussions and all of the references that I found regarding local production of vaccines, it is important to be aware that this absolutely excludes production of vaccines that are dependent on messenger RNA, which are Moderna, Pfizer vaccines, for example. This is because they require infrastructure and skills that neither the continent nor the region necessarily have. In addition to the storage and transportation capacity, which is not suitable at all with the current infrastructure that these countries and countries in the region have. So we're excluding these from the equation. Now, if we put this aside, there have been discussions of 5 regional production hubs happening in the Middle East and in Africa. And regrettably, none of these discussions, none of these negotiations between the companies that are producing the vaccines and the countries with the intention of actually creating these regional hubs have been made available publicly or in a transparent way, which really outlines the governance and the transparency issues that are at hand. But this is probably because when it comes to any negotiations that has to do with medications, vaccines, or health technologies in general, these are very tough negotiations that are in place. There are lots of considerations, including pricing, profitability of the companies, but also what is the company getting in return. And what the company can be getting in return does not necessarily have to be money. Sometimes these contracts are negotiated based on benefits. These benefits can include what they call negotiated clinical trial packages, which means that we're going to be helping you in installing these local production facilities, but you're going to be able to support us in our clinical trials. In some cases, countries would actually request some tax exemptions for their other products or market access for other products that they're producing. And all of these enter in the equations. When we put this in mind, we need also to consider the fact that the Gavi Alliance and the COVAX facility and its capacity to supply vaccines for countries with limited resources is actually a hampering element in these negotiations, surprisingly. Because they look at this as something that creates some sort of market failure. They cannot negotiate with the same aggressiveness as before because there is an option that the country can actually get these vaccines for free. So the estimations of the market and the market value of what they're producing actually enters heavily into the conversation. Egypt has been, so we're talking about 2 major production facilities, one in Aguza, which is pretty much in central Greater Cairo. And the other is a bit further in 6th of October. And according to the statement from the Ministry of Health, the new one in 6th of October is really a massive production facility with the capacity to produce, and let me get you the figure exactly. Yeah, with the capacity to produce over 3 million doses per day of the vaccine. Now, back to access to information and to the kind of conflicting messages we're talking about. If you look at the numbers that are provided by the government and provided by the different media outlets, they're extremely contradictory, and they're not necessarily consistent with what people would be able to perceive as credible information. But this is because it's pretty new, and statements in that case tend to actually vary depending on the source. So you will have statements from the drug coalitions, the pharmaceutical company coalitions, that would be severely contradicting with what the government is saying. In Morocco, the situation is quite similar, but the intention may be a bit different. In Morocco, the official statement is that local production is fueled by and I'm quoting the official statement, this is to provide the kingdom with complete and integrated capacity, okay, that would eliminate any external dependencies and political contingencies. They are seeking what they call health sovereignty, which means that the government doesn't want the country to be dependent on foreign aid or foreign sources for the vaccine. In Egypt, the government statement in that regard is that it wants to position Egypt as the regional production hub for the entire continent of Africa. In that case, there has also been further discussions of a South Africa, Nigeria regional access point for the production of vaccines. In the end, this is largely not transparent. It's not very clear how things are going to go. The numbers are like the margins and the discrepancies in the numbers is just striking. And in the end, one thing we have not learned through this entire process is the importance to properly engage the populations, civil society, to be transparent in the kind of information, and to understand that although negotiations tend to have a secretive aspect, this is a matter of public health. This is a matter of national policies. It affects people's lives, and it cannot be dealt with as negotiations and other elements related to any other commodity which countries need to negotiate, like wheat or basic supplies.
Yes. Yeah. Thank you, Ayman, for the lengthy answer on this. And you did mention very important points on if it has wanting to create a health hub for the region or the continent, or wanting to be more of a sovereign country when it comes, or autonomous country when it comes to, let's say, production of vaccination, but also manage the pandemic well and not rely on external aid. And because there have been like delays in COVAX and so on, and the vaccination companies have had delays. So this probably has massively impacted vaccination intake, rollout, and also all sort of accessibility. In terms of having maybe potentially creating these health hubs, probably with a political background in place, and it differs between different countries. Jasmin, do you think this will perhaps encourage vulnerable populations to trust more the governments, or maybe because if potentially we have vaccines produced in the region, would this encourage them to take it? And what do you think? What do you think is the one potential political connection to that?
Unfortunately, when it comes to refugees, the connections in the areas of vaccine diplomacy in the region are purely political. Vaccine diplomacy in the region essentially just means that it's going to be used as a tool for soft power projection. And as much as vaccine supplies and their production in various countries in the region would promise relief, they are also highly connected, and they interact with pre-existing political and foreign policy initiatives that each of these governments are very cemented in and don't really move around. There's no room for maneuvering there. So when it comes to refugees, the production itself or the supply itself does not essentially affect them as much as it does the mainstream population. I say mainstream, the citizens of a given country. While we wish to look at the MENA as kind of a homogeneous region in the areas of vaccine diplomacy, we can essentially break up the MENA into three different groups when we look at how the position and agency of countries in the MENA in the areas of vaccine diplomacy interacts with prior political trends. So if we are going to divide it between the leaders in the region, in the areas of vaccine diplomacy, the UAE, Turkey, Morocco, etc., we will then trickle it down to the middle group that kind of would maybe catch up on the short to midterm future, countries such as Saudi Arabia, Egypt, Tunisia, even Jordan and Algeria as well. And then kind of the countries that are severely challenged in launching any successful vaccination campaign, let alone the production or a successful model for vaccine diplomacy. Countries that lack the state capacity, the financial capacity, and the political stability, like Syria, as we said, in its different regions and different authorities there, Yemen, Libya, Sudan, even Iraq in that regard. So unfortunately, when we try to link vaccine diplomacy to vulnerable groups, and particularly the refugee population, their access is very isolated from the way the rest of the citizens experience this, and they're rooted in political and foreign policy stances that kind of manage this. The production itself, to answer your question, would not necessarily, in my opinion, impact the refugee population and their access, because the challenges that refugees face in accessing the vaccine are very different than the rest of the population. As Joey said, and as Aula said as well, the routes of communication are flawed, essentially, even to begin with. Everything going on, sometimes outside the refugee bubble, if I may, is very foreign to them, no matter what is going on in the areas of vaccine diplomacy or production or supply. Not affect them. The reforms have to happen, in my opinion, first in the areas of communication, and then we can talk about the political implications of how these populations will gain access.
Yes, thank you, Jasmine. And I'd like to continue with Aula and ask about, because Aula, you mentioned before the politicized public health system we have, especially in place of conflicts. But then how would you see this intersection between this vaccine diplomacy, its political connections, and being used as, vaccines being used as political agents, Jasmine mentioned as well. So how do you see this evolving in countries of conflict, and not only among marginalized population, but basically countries facing disasters?
Yeah, so actually, I think it's been very interesting watching the evolution of the discussions around the COVID-19 vaccine, including the race to be the first to have it approved and marketed. I saw a nice classification from the Middle East Institute around vaccine diplomacy, and they framed it as international vaccine diplomacy, mainly by Russia, China, and the EU, regional vaccine diplomacy by the UAE, Morocco, Turkey, Egypt, and Israel, and then also the relationship between vaccine rollouts and domestic policies. And I think that captures the issues rather nicely. Again, I'm going to speak about Syria because it's been really fascinating witnessing who is trying to provide vaccines, whether through the COVAX initiative or elsewhere, and a lot of the negotiations that are happening. And also to see, so for example, Syria has received vaccines, as I said, from the Serum Institute in India through the COVID vaccine, through the COVAX initiative, is one of the AstraZeneca vaccines, but also from China. And very interestingly, there's been a very interesting negotiation between Russia, Israel around the Sputnik vaccine. And I don't know if any of you caught the story earlier this year, and it's one of those that you really can't quite make up. So apparently the negotiations around the vaccine also took part around hostage negotiations of a particular prisoner from Israel, who was then returned around the time that possibly the Russian vaccine went into Syria. So all of this is very fascinating. It's very politically murky. And of course, a lot of the, and Jasmine said it very nicely, it's the soft power vaccine, but also some of the negotiations around water access. So for example, Turkey is quite an important player in the region. and of course, very important in terms of the discussions around water. And also, perhaps it's taken a play in some of the discussions around territory. So all of these tie into the politicization of our health and humanitarian system, our public health systems across the region, but also seeing how these international powers are using their influence through the COVID-19 vaccine. There is something that we haven't addressed as yet, and it's beginning to tie in with vaccine hesitancy in the region. And so some people might say, I don't want the Russian vaccines. So the Russians have been responsible for significant IHL violations. Other people might say, we don't want the Pfizer vaccine. Other people might say, we don't want the India vaccine because we don't think it's made to the right standard. And I think all of these have very important repercussions as to how we vaccinate our populations in the region, alongside the misinformation that is occurring in these very traumatized populations who've lived through, in the case of Syria, almost a decade, more than a decade now of protracted conflict.
Thank you, Aula, for these interesting anecdotes, if I might say, or stories, and highlighting, let's say the soft power or like the political connections when it comes even to health. It just keeps on amazing me sometimes. Joey, if we might touch on how like we can influence misinformation, disinformation through these health hubs, if I want to say, or these vaccination health hubs. Would you think this might positively impact it or negatively impact it? With this, what do you think of this issue?
Yeah, it's an interesting question whether or not domestic production will, enhance trust in government programs around the vaccine. And I think to some extent, perhaps it might play on folks, nationalism and loyalties and whatnot. But I think that more broadly, there's like many more efficient public health communication strategies rather than domestic production. Domestic production fits different needs. They fix, they address supply needs, capacity issues. But in terms of communication and addressing hesitancy, as I said previously, you need to have clear, concise messaging. It needs to be consistent. It needs to be science-based, and you need to meet communities where they're at. And I think that there's no substitute for that kind of messaging and a sort of broad national and even regional strategy as well. And also, you're not going to build public trust in government and in governance through a domestic production program. Public trust is built through years of messaging over different issues, and it's been built throughout the course of the pandemic. And just because you're producing vaccines doesn't mean that is going to build public trust. Your previous ability to communicate case numbers, in the way that you've communicated lockdown measures, all of these factors from over a year ago are more important than your ability to produce one vaccine or many different types of vaccines. So while I don't think it's nothing, the impacts, I don't think that it's completely negligible. There's just many more different tactics and strategies of communication that are much more effective.
This is an interesting view to see. I think we'll have to wait to see if we have these production sites in place, if this might enhance trust in government and speed up of the vaccination. I would like to remind our participants, if you want to submit any questions, now is the time. I do still have actually two quick questions for our speakers, but then I'll be taking questions from the audience. So I wanted to ask, and I think one of you did mention this. I'm not sure if it was Jasmin or Aula. I'm sorry about that. But how do you think vaccine access has been for detainees, prisoners in the region? Not perhaps just political prisoners, but just in general. So if you have any information on that, or if you want to add to this.
only to say that it's been severely neglected. So across the region, we have a lot of detainees. We have migrant populations coming up from sub-Saharan Africa, particularly in Libya, where the situation is devastating. And I would say it's very unlikely, despite the very significant risks of these populations, usually in close quarters, poor ventilation, poor access to nutrition, that they're certainly not being prioritized for COVID-19 vaccination. In northeast Syria, there is a large number of children, sadly, who are in detention, held in the most abominable conditions, and we're concerned about other infectious diseases outbreaks. And again, obviously they're children, so they wouldn't necessarily be priority for COVID-19 vaccine, but certainly other detained populations in Syria won't be prioritized. We don't know the exact number of detainees in government control in Syria. I've seen wide estimates because of course there are forced disappearances, and of course it's not something that's particularly well recorded, and deaths of course are not recorded, but we think there may be over 140,000 detainees, and that includes men, women, children, held in abysmal conditions where outbreaks of communicable diseases, whether COVID-19, which will thrive in that situation, especially with poor healthcare in populations without adequate nutrition, ventilation, or any sort of access to medical care, will spread through that population. And I would suggest that they're very much not being prioritized or perhaps even taken into account in terms of COVID-19 vaccines. In terms of other countries, I don't think I can comment, but I would be, again, unsurprised if these very marginalized populations are not being considered, especially as we know that internally displaced people who might be living in camps or tented settlements themselves are not necessarily being able to be vaccinated in the way they need to be.
Yes, this is very sad to hear and to learn, but unfortunately it's the situation, and I think it's also the case for Lebanon among prisoners. But I've heard there was a vaccination drive occurring in Rumia, and there was like maybe AUB, I think, if I'm not mistaken, also wanting to vaccinate some prisoners also, and Médecins Sans Frontières also targeting those populations. I don't know, Jasmin, if you want to add to that.
So a while ago, I remember around September last year, the buzz was that 200 detainees in Lebanon's capital prison, obviously in Rumia prison, did contract the virus, and the Lebanese Medical Association held a news conference, and the Doctors Syndicate and whatnot, to say that they're going to start to adopt preventive measures. A few months later, there was a small report that about 20 to 30 people between inmates and personnel that had contracted the virus as well. Last, my personal knowledge is that they allocated 2 hospitals in the Bekaa governorate and in Beirut to actually vaccinate the 4,000 inmates, if I'm not mistaken. But it's not my area of expertise, but that's my knowledge on the subject matter.
Yes, thank you. Another question, going back a bit to vaccines, well, let's say a political implication. So you know that many countries, especially the EU, for example, are applying vaccines passports if you want to, move between countries, or if you want to access any indoor or maybe touristic areas. Do you think as a region we should apply these vaccine passport, let's say, policy, or yeah? So what do you think of this issue, basically? Not going to add more questions to that, but I'd like to hear from you. So please, for the speakers, feel free to unmute yourself and start.
Yeah, so allow me to actually say something about this. Surprisingly, in Tunisia, one of the main reasons why vaccine distribution has been let me say not optimal is because it started with they had a first batch of Pfizer vaccine, okay, and then it was over. They didn't have any further, and so they only had the Chinese vaccine or other types of them. And so many people were actually waiting for additional patches from the Pfizer vaccine, or in some cases in Egypt, the AstraZeneca vaccine and such. And this is all tied to two things. First of all, a perception that other vaccines are less effective. And since I'm going to get one vaccine, then why take the one which is less effective? The second is related to this idea of vaccine passports and restrictions in travels. And, the EU has been clear on the kind of vaccines it accepts or the one that it doesn't recognize and these sort of things. And this is really causing a major problem because in the end, people are comparing not receiving the vaccine that would allow them to travel or to go places, but not necessarily considering the fact that if they don't get any vaccine, their health is put at risk. And I think it's very, I understand that there are inequities around the world, but the inequity in the conversation, the idea of putting these vaccine passports as a topic, as a new restriction that affects vaccine distribution in other countries, I think it is completely detached from reality, and it is something that can easily be done in a way that is less offensive and less provocative, especially that these vaccines are still not considered. They didn't have the sufficient clinical trials to be considered fully safe. Those who are getting the vaccines right now, they have to sign a consent that they are assuming responsibility for anything that happens to them. So the government is denying any responsibility for anything that might happen to you because of the vaccines. Pregnant women, they don't necessarily know whether it is safe or not safe to get these vaccines. And if you put all of these situations into consideration and then end up asking people to get vaccines, because then they would be issued a passport which would allow them access to areas and not the others, then it becomes a chaos of public information, misinformation, and intentional confusion that is absolutely not helping anyone. And the WHO has to play a clear role in that, because it's really, and I have seen people who got COVID, who died from COVID because they were waiting to get the vaccine that would be approved in order to be able to travel and to take their kids on vacations. And it's really, it's for me, this is like the lowest point when it comes to vaccine equity.
I may add here, I think vaccine passports, I mean, this might not be a very popular opinion. It's a two-side of the coin. While from one point it might exacerbate inequities because there's this a very selective mindset when it comes to vaccines and what we want to choose, as you were mentioning, Ayman, that we want to get like the best one, or well, there's no best one. All of them are protecting us from hospitalization and severe infections and severe basically disease. And there's also the fact that we've all, so I remind myself sometimes that we've all have the vaccination cards from when we were young, and sometimes to travel to other countries that have endemic diseases. So for example, Egypt is one of them, or Africa, you would need to get a set of vaccinations. So there's this two side of the coin, and it's very confusing for everyone. And while perhaps like the response to COVID hasn't been unanimous in terms of different countries coming together to really respond to the pandemic and really ending it, they come now up and they want to say, like, let's have a vaccination passport and trying to protect ourselves, while there have been very much less inequitable measures that they could have taken to prevent this this pandemic from progressing to this stage.
Allow me just to add something to that. I think the main difference between vaccination cards for yellow fever, for example, if you're coming from Brazil, or if you're going for pilgrimage in Saudi Arabia, you need to get vaccines from against specific diseases. The main difference is that these vaccines are available. WHO is making sure that they are available in different countries, and you have the option of doing that. But when you don't have access to the vaccines that are recognized in these passports. When these passports are not acknowledging what the WHO is recognizing as eligible vaccines, then it becomes a problem. When you are not supplying people with sufficient information that prove that these vaccines are safe and that they can take them, then you cannot ask for the, you know, it's a balance that needs to be considered. And in the end, you need to, for example, and let's take it to an extremely local level. Let's say, for example, that, you know, I'm in the management team of a school that is planning to open its doors for the students at the beginning of the school year. And I want to make sure that the school is safe for all my students. So I want to vaccinate my entire team, and the entire team is willing to get these vaccinations. If they can't access the vaccines, if they don't have it available, if they sign up on the system and then they end up not being eligible because it's not their turn to get the vaccine, how can I actually say that I'm not going to give access to the school except to those who got vaccinated, if some people would want to get vaccinated, but they won't be able to get it? So this is the thing. This actually works for countries like in the US, for example, where they have more doses than number of people. So I understand, because, you know, in this case, you are trying to motivate people to get a vaccine that is available. But if it's not available or not accessible, then, you know, it's completely bipolar. Let me put it this way.
I think one more thing to consider. I'm so sorry to interrupt you, Ghinwa. I think the sound's a little delayed where I am. I'm so sorry. Another thing I think to consider is that for the refugee community in the region, as well as the high numbers of individuals that are stateless and non-registered and don't have paperwork, this concept of a vaccine passport just creates an additional layer of documentation that they don't have, an additional barrier to their movement that they don't have. And I think the manner through which these debates are being communicated to this population is scaring them very much. I remember being in a situation where we were conducting some field work, and the COVID, of course, vaccine coming up, and them discussing this whole concept of passports, and a little kid looking at me, telling me, so if I have a vaccine passport, does that mean that I can leave the country? And I go, no, you need a passport and you need a vaccine passport. And this little kid hits on his head and he's like, there's another document that I need now that I can't get. And I'm thinking, it's such an indicative little story of a larger scale problem. So as Ayman was saying, you cannot isolate the subject matter from the different factions that it affects. It would be very easy for me to get a vaccine passport. And if that's what's required of me to go on vacation, then that's one thing. But for someone else that's already struggling with registering a new birth that does not have any form of documentation, that is stateless, this is just another form of documentation that would prevent them from moving. Further placing them, you know, down the line and in the long run at the bottom of the bucket, really essentially as to how much freedom of movement and accessibility they have. We're just adding another layer of discrimination against people that are already very vulnerable. And I think because this is recorded, that's all I'll say on that. Thank you very much.
Oh, thank you, Jasmine. Aula, Joey, would you want to add any points on this question?
Okay. No, I think all the points have been covered. I mean, it really is about widening inequality. And also, very sadly, like Ayman says, you know, people may hold out for certain vaccines. And it's important to note that Covishield, which is the vaccine that's produced by the Serum Institute in India, in most countries, I think there's only 5 EU countries that will accept that. So again, it's quite restrictive, and people might say, look, through the COVAX initiative, you're giving us a vaccine which you're not giving to other populations, and it's causing us further restrictions.
Yes, I think this was mentioned, but again, this pandemic has only added to the levels of inequity we have from the different measures, the drastic, perhaps draconian measures, if we want to say, related to lockdown, and then the vaccine passports, and every other measures in terms of accessibility to just anything, and basically during the pandemic. Just perhaps to end on a more, let's say, in terms of lessons learned and a more of a positive note. So my last question to you, and let's please keep the answers a bit brief so we can end on time. And this, well, let's say that, you've mentioned that, governments have policies, strategies in place to respond to the pandemic, and to also, vaccine strategy in place to, for the rollout of the vaccination campaign. But there has also been mentioned throughout your different answers the roles that civil society has played, and humanitarian sector perhaps, or also community centers, or basically national societies and national civil society. So we know that the government have a primary responsibility when it comes to responding to the pandemic, and when it comes to rolling out the vaccination campaign, and preventing misinformation, disinformation, and so on. And while civil society, probably the humanitarian sector, did step in also as well in some spaces. But can you tell us more perhaps about these initiatives and the roles in terms of how they did step in? How did they help in enhancing vaccine intake? How did they help in taming misinformation, so on? So the floor is yours.
I can just step in very briefly. The role of civil society and advocacy organizations, especially in combating mis and disinformation and conspiracy theories, is hugely important. And I feel like, especially at the beginning of the pandemic, these groups were the only groups who are really doing meaningful work on, fact checking and getting out, taking the time to really dispel different conspiracy theories that are run abound. So I think it's important to recognize that, obviously there needs to be a state government response as well, and there also needs to be a response by social media companies. But I would say for the majority of the pandemic, that burden has fallen, whether justly or unjustly, onto these civil society groups. So yeah, I think that those partners are hugely important, and that's the way forward. If they could receive more support, and resources, and could work with social media companies and with the state, that would be ideal. But up until this point, I would say that they've been doing the majority of the work in combating disinformation and conspiracy theories.
Yes, thank you, Joey. Aula, would you like to add any point before leaving?
Well, just to say, actually, you've hit the nail on the head. It's civil society organizations, or actually beyond that, community-led organizations, because arguably communities, one, vary across countries, across the region, and they are probably the best advocates, arguably, for what they need, and also they'll understand the needs of their local community. And it's also an important way, particularly for us in the region, for communities to feel empowered, and also to, I guess, encourage self-advocacy for their needs. So it's not for me or anyone else to tell these communities what they need. And I think it's also a way for local disinformation or particular contexts to be discussed and addressed at a very local level. And then just on that point, what's very, very important are the international discussions around the localization of humanitarian aid. So of course, a lot of money has been provided to various humanitarian organizations, but we must all be enforcing the need for funding to go directly to these local civil society organizations. One, because it's cost effective. Two, they're often from within the community. Three, they're often better trusted. And four, they've demonstrated they can do the work often on a shoestring through sheer will and heart. And arguably there's been lots of examples where they have been effective, going in amongst refugee communities, internally displaced settings, and really talking to the community about these issues that they face.
Yes, very important points to consider. I'll give the floor to Jasmin to add on, because it's the same topic on refugees.
No, thank you. I think Aula covered it brilliantly. I think often enough, whenever we're dealing with a humanitarian crisis, we're dealing with international organizations. We come down through a top-down approach. We have this kind of international universal model, this stencil that we're going to apply to every setting and every region. And I think in the debates on humanitarian interventions and how we're dealing with crises in general at the international level, this approach is slowly and slowly diminishing, which is, I think, a very positive thing as well. I think participatory approaches with organizations and communities on the ground have proven to be hundreds of times more successful sometimes than taking in a big UN agency, a big NGO onto the ground and speaking to people in languages they don't understand, communicating to them in manners that are sometimes offensive, that are unfamiliar to them. And I think this kind of participatory approach is pivotal for this, for COVID and for any humanitarian setting, as well as Joey and Ola said. Thank you.
Ayman, any other points to add?
Yeah, I would just say that it's important to make sure that civil society is engaged not on a paternalistic way. Public information and dissemination of information related to COVID or anything has regrettably been very paternalistic. Wear masks, social distancing, avoid crowds, and that's it. Information needs to happen both ways. You need to include civil society and stakeholders in discussions about strategies, and then decide together on what needs to be done rather than just preach and give one-sided advice. And I think this is the lessons to take for all countries in the region. Otherwise, it's going to be a very fragmented intervention.
Thank you. Thank you, Ghinwa, for that, for moderating such a fascinating conversation. And thank you, Ayman, Joey, Jasmine, and Aula for your insights, expertise, and time. We're so glad we've been able to convene this group, and we very much intend on continuing the conversation. Since the onset of COVID, we at TIMEP have attempted to tackle the pandemic from a variety of different angles, from misinformation and disinformation to even the impact on due process and access to justice. I invite you audience members to continue engaging with our work on public health by reading our analyses, attending these events, and engaging with our fellows. To our audience, thank you so much for your questions and your attention to this timely topic. And to the TIMEP team who made this event possible, I'm eternally grateful. Thank you all and have a wonderful rest of the day.
Thank you very much. Bye-bye.
Thank you. Bye-bye.
Bye-bye.